I'll now invite Hannah Han. Hannah is from the Institute of Health Metrics and Evaluation in the United States, and she'll be combining two talks in one. She will talk on the prevalence and mortality trends of hepatitis B and C infection in Sub-Saharan Africa, a systematic analysis of the GBD 2020 study, and the trends of hepatitis-associated cirrhosis and liver cancer in Sub-Saharan Africa, also a systematic analysis of the GBD 2020. Go ahead.
Good afternoon. I'm Hannah, again. I'm from Institute for Health Metrics and Evaluation. We are based in Seattle. I'm still jet-lagged, so hopefully I stay coherent throughout the presentation. But if I lose you in any chance, please feel free to ask me after my talk. So I am pleased to share some preliminary results from our latest iteration of the Global Burden of Disease study. Used to be called 2020, but as of last month, we started calling it 2021. Specifically on the burden of chronic hepatitis, hepatitis-related liver diseases in Africa. So I want to start by giving you a quick introduction of what GBD is and how our work in GBD fits into the ongoing conversation we've had in the past 2 days about some of the challenges that many African countries have been facing in terms of data collection and policy decision-making to eliminate hepatitis in the continent. So GBD is defined as a large systematic scientific effort to quantify the comparative magnitude of health loss due to 369 diseases and injuries and risk factors by age, sex, location over time. So in GBD, we strive to use all available data out there, whether that is data from the published literature, cancer registry data, vital registration data, verbal autopsy data, and we try to apply a standardized method to all of these data sources of different epidemiologic measures to produce internally consistent mortality and morbidity estimates in 204 countries and territories between 1990 to present. One of the strengths of the GBD study is that we have a number of sophisticated and powerful modeling tools that allow us to synthesize all of these data to not only produce the burden estimates in the locations where we have data, but to use this data as a prior to help make the best prediction of the burden estimates in the locations where we do not have data. And another strength of GBD is that it's done iteratively, meaning we produce estimates almost every year, incorporating new data, new methods to improve our burden estimates. We have, in addition to about 400 staff currently working in Seattle in GBD Enterprise, we have over 8,500 collaborators all around the world. Of many are interested in the liver disease estimation process. So going over some of the methods on how we estimate the burden of hepatitis. So the burden estimation of chronic hepatitis and hepatitis-related liver diseases in GBD involves a number of statistical models to synthesize the primary data sources, and then we apply some additional modeling assumptions and steps to adjust and produce the final burden estimates in all of these locations. So in today's talk, because of the time, I'll be focusing on these 3 indicators, which are the hepatitis B seroprevalence, accounting for hepatitis B vaccine coverage, and the second one is hepatitis C incidence, accounting for hepatitis C treatment, as well as the prevalence. And that lastly, I will go over the hepatitis-related disease burden in terms of mortality for both hepatitis B and C. So to estimate the first indicator, the hepatitis B seroprevalence, we first analyze the primary data, that sero data specifically, in a population that are not exposed to vaccine, which we call counterfactual model. And then we apply the hepatitis B vaccine coverage to subtract the number averted from the counterfactual to produce the true hepatitis B prevalence estimates. And for hepatitis C, we also produce a counterfactual model where in locations where the hepatitis C treatment is not implemented. And then again, we subtract the cases averted due to hepatitis C treatment to produce the true hepatitis C seroprevalence estimates. And lastly, for the mortality of hepatitis-related burden, we sum up the total cirrhosis, total liver cancer, acute viral hepatitis envelope, which are then split into different etiologies using the data from case series. And then we sum them up to produce the total hepatitis-related burden, mortality burden. Here I'm showing some global map of where we have primary data for all of these 4 indicators between 1990 to 2020. You can kind of see the amount of data we are using in our models. So moving on to the results. So our analysis shows that the prevalence of chronic hepatitis B in year 2020 is about 3.6%. And then for global prevalence of chronic hepatitis C is about 1.6%. And then you can see in the map that a lot of hepatitis B prevalence burden is coming from Asia and Sub-Saharan Africa, the countries marked in red. And then for chronic hepatitis C, a lot of prevalence burden is coming from Eastern Europe, Southeast Asia, and parts of Sub-Saharan Africa. For mortality rates of total hepatitis-related diseases in 2020, again, which is the sum of liver cancer, cirrhosis, and acute infection of hepatitis, a lot of mortality burden for hepatitis B is concentrated in Asia and Sub-Saharan Africa, again, illustrated in the color. And then for hepatitis C-related mortality burden is concentrated in North America, Europe, Southeast Asia, and parts of Sub-Saharan Africa. Now zooming into the African continent and comparing it to the WHO's global interim targets for hepatitis B and hepatitis C. So the prevalence of hepatitis B in Africa, like under children under 5, ranges from 0.5% in North Africa to 5.1% in Central Sub-Saharan Africa. You can see that the prevalence burden in young children is concentrated in the Western Sub-Saharan Africa and Central Sub-Saharan Africa. Looking at hepatitis C incidence burden in Africa, again in 2020, incidence ranges from 72 per 100,000 in North Africa again, and then the highest is found in Central Sub-Saharan Africa at 157 per 100,000, followed by Western Sub-Saharan Africa at 128 per 100,000. Looking at the regional hepatitis-related mortality rates, here we see something interesting because in the previous slides we saw that North Africa had the lowest prevalence of hepatitis B under children under 5, as well as the hepatitis C incidence. But here, North Africa has the highest mortality burden coming from hepatitis B and hepatitis C. And then that suggests that when you look at cross-sectionally, if a country does really well in terms of reducing the prevalence and incidence of hepatitis B and C, the downstream effect from cirrhosis and liver cancer will be lagged. So that's why you see the higher mortality at the cross-section of year 2020, but lower rates of prevalence and incidence at the same time period. We can also look at the data slightly different ways. So here on the right, I am showing the proportion of hepatitis B-related mortality rates and hepatitis C-related mortality rates by the proportions of different diseases contributing to the mortality in different regions. And then here I am showing the progress that's been made in the last 3 decades in 5 different African regions. There has been a great success in reducing under 5 hepatitis B prevalence, hepatitis C incidence, as well as mortality. Southern Sub-Saharan Africa has mean estimates that's around 0, but this is the region that had low burden of hepatitis B to begin with, so they were kind of staying still. So another way to look at the temporal trend is by plotting the yearly rate from 1990 to 2020. On the left, I'm showing hepatitis B-related mortality, and on the right, I'm showing hepatitis C-related mortality, stratified different African region. So in summary, we see large variations in the levels and trends of hepatitis-related burden in Africa, and there has been a progress made in reducing hepatitis B infection in children under 5, as well as overall HCV infection. There has been a slower progress in reducing overall hepatitis-related mortality rates in some parts of Africa. And then we see the significant long-term effects of past and current infection of hepatitis B and hepatitis C will be lingering with us for a while, so that the healthcare systems needs to be prepared for this burden. Although GBD does a really well of predicting the estimates for the locations where we do not have data, there's still a need for primary data in Africa to refine our model estimates. Some of the indicators that we are looking to extract more and hoping to include in our models are hepatitis B surveys and as well as the hepatitis C survey data. And then we also want to incorporate the treatment data for hepatitis C to expand our treatment database. And then we would like to expand our etiologic database as well to help us better split out the cirrhosis and liver cancer envelope into different etiologies. And lastly, we would like to have look at the impact of COVID-19 on hepatitis B and C on testing and treatment services. So GBD is a critical resource for policymakers, researchers, donors, and others to make informed policy decisions and guide public health priorities. So hopefully you find this presentation useful and help us disseminate the findings and move the public health priorities forward. Thank you.